Hey everybody, can you hear me okay? Everything's good? We have Dave here, and we just met. What a great way to meet a person. And we're going to place an implant in the edentulous number 12 site, and he also has some resorption in his maxillary central incisor. So we're going to extract and graft and place an immediate implant as possible, and we'll demonstrate that. Before we begin, let's just look at the CT diagnosis, and we won't go into a lot of detail here, except that if we see we have the number 12 site here, and then we have a sagittal view of that site, and we can simply manipulate the system by doing a measurement of the vertical amount of hard tissue available and the amount of horizontal hard tissue that's available. And we can see we have, as we discussed throughout the course, we have about 8 millimeters of precise horizontal bone available. And because we have a bicuspid area, we are going to place an implant about half the diameter of the tooth we want. So we could possibly place a 3.5 or a 4.3 diameter implant. We have plenty of vertical height in excess of 15 millimeters, but we don't have to put that long of an implant in there. We could certainly put an 8, a 10, 11.5, or 13 millimeter implant in that site. But if we go, I'm just going to manipulate the CT here and go to the number 9 site. Number 9 site. You can see, as we saw preoperatively, we have some resorption in this tooth, and you can see how the tooth is positioned, and the facial plate of bone is very thin in that area. So we want to atraumatically or minimally traumatically remove this tooth very precisely, and then in this area too, we will think about placing the implant in this dimension, this direction. Remember, we talked about we'll make our initial osteotomy 3 millimeters palatal to the facial aspect of the adjacent teeth. And we can also see the amount of horizontal hard tissue we have. There we go. So we have plenty of vertical height, and then we'll decide which width of implant we want to use. But if we go intraorally now, so if we look at the available site, we can see we have a missing bicuspid tooth, and we basically are thinking tooth up in this situation. So we want to place the implant about half the diameter of that space. So I would probably say a 3.5 diameter implant would be ideal in that situation. We've already anesthetized the patient, but as we said before, we're always evaluating the amount of attached gingiva we have in this situation. Now, we talk about different protocol or different techniques that we can use. We can use a flapless or a punch technique, or we can reflect the tissue. If you're not sure about a certain situation, then it's always better to reflect the tissue. So let's start with this edentulous space first. And again, I always tell the patient, you're in control. Anything bothers you, if you could just raise your hand and we'll get this done, okay? So what we're going to do is I'm going to take my Orban knife. And again, we talked about this before. It's a sharp stainless blade. And I'm going to make a crestal incision to hard tissue, to the adjacent tooth. Nice clean incision. And because we're not going to make any vertical incisions, we're going to go around the tooth about halfway. We're going to try to stay away from the mucogingival line. We're not making any vertical incisions, which will eliminate prostaglandin and histamine release. And I was talking to you earlier about the grafting kit we created. This is a nice grafting kit, relatively inexpensive, and it has all the apparatus that you'll need to be able to do your surgical reflections and grafting procedures. So what I'm going to do is you want to be a little bit forceful, but can you see how I'm just kind of like peeling it like an orange? Peeling it like an orange. I don't have any problem reflecting the tissue to the mucogingival line. I'm just not making any vertical incisions in that area. So you can clearly see, if you can touch in, that we can see the facial plate of bone in this area. And if we want, we can even reflect the palatal area. Are we doing okay? So that I can see the entire crestal plate. This allows me to actually visualize the positioning of the implant. And my favorite motor is the Aseptico motor from Glidewell. And you can see I like to go about 800 RPMs. I'm not so concerned about Newton centimeters at this position. As we've gone through before, we are going to take our 2.4 pilot burr, and I'm going to make my initial penetration through the cortical plate. We're looking at mesial, distal, buccal, lingual dimensions. So I can clearly see, if you wanted to do your field goal post, you could do that. But to expedite, I need you to open this a little bit here. I'm looking at positioning that implant along the central groove area, and I can clearly see positioning of my implant placement. And I'd like you to use two hands if possible. I know for video demonstration it's a little bit challenging, but and I'm pumping. And I'm simply going about 4 millimeters. And at this juncture, we could take a radiograph. And see our positioning. But again, to expedite, I think we understand the process. I'm then going to take my 3.0 diameter Han surgical burr, and you can see, I'm going to do an 11.5 here, and you can clearly see the marking. And because I can see the hard tissue, I will go to the crest of the ridge. And again, using two fingers is sometimes difficult for video demonstration. It looks like I'm in pretty good position. And I'm simply going to final position. I'm then going to take my final osteotomy burr, my 3.5 diameter. And again, back off just a little bit there, going to, yep. And you can see I'm at the crest of the ridge. Suction, please. Thank you. And basically that is my osteotomy. We're going to take a 3.5 diameter by 11.5 implant to 15 RPMs, 35 Newton centimeters, or we can even bring it back down to 25 as we talked about in the program. And we will use our handpiece to place the implant. So I'm squeezing one end of the clothespin. It's going to snap in, open the clothespin, and it comes out nicely. And always get in the habit of running to see how slow it's actually turning. Now I don't mind the red blood cells in this area, and I'm going to go ahead and simply place the implant very slowly. I'm watching it go in. And you heard that sound, so we're torquing out. but I'm not at depth yet. So what will we do next? We will simply take our torque wrench. And remember, I don't care so much about torque, I care mostly about position. So my torque wrench here is set at 25 Newton centimeters. That's where we torqued out. I'm going to take my inserting tool and my extender, and I'm going to go to site, engage, and then place my torque wrench in the position, and turn to me just a hair. Thank you. And I'm looking at position, and you can do this radiographically. I still have a little bit more to go, another millimeter. Remember, 4/4 turns is, so I'm going here, 4/4 turns is about a millimeter, so if I do 4/4 turns, I should be right on, if my math is correct. Here I'm going 9 o'clock, 12 o'clock, 9 o'clock, 12 o'clock, 9 o'clock, 12, and it clicked. So I'm now turning it up to 30 Newton centimeters. 9 o'clock, and it clicked again. 35 Newton centimeters. And it clicked again. So we're getting tremendous stability. Remember where we're getting our stability from? In the apical 2 millimeters. And it looks like we're in really good position there. We're right at the crest. Now to simplify things for our patient, as far as transitional, because we did get to 35 Newton centimeters, certainly we could put a healing abutment in, but I'm going to go ahead and put a flat cover screw in that site and then suture it closed and let it heal so he could wear his transitional. Now you will be doing radiographic evaluation of this site, but we can certainly see that we have good facial plate of bone, a good amount of facial plate of bone, and we should get an excellent situation. So we'll suture this area quickly. And here I'm using the suture provided by Glidewell, the polyglycolic acid suture. This is resorbable. It's purple in color. It's very easy for me to see, and you can certainly get these through your rep at Glidewell. And I'm simply going to put a couple quick sutures in here, and we'll be done with one implant. And here I'm just doing a couple interrupteds, maybe 3 interrupteds. Make it really simple for the patient, and then I'll give you a little breather, okay? You doing all right? Awesome. You'd almost think I knew what I was doing, huh? Yeah, I'll just do a couple interrupteds here. 2 forward. 1 in reverse, 2 forward, and then you can snip that up. And let me do 1 more here. Very, very nice sutures. And 1 more here. So I'm not exactly sure how long this procedure took, and obviously we didn't stop to take a lot of radiographs just to expedite the procedure, but it certainly no more than a 20-minute procedure for the patient. And then whenever you finish the surgical procedure, I always give a good squeeze, remove any excess RBCs in that area. And as I mentioned, I like to give a little bit of a steroid post-operatively, dexamethasone sodium phosphate, 4 milligrams per ml. I'll give 1 cc in a syringe, and I'll just go into the vestibule, and this will help eliminate any swelling. Post-operatively, we tell our patients ice to the outside of the face. We'll give you a little ice bag, and I use the term religiously. Try to allow keep the area cold. That'll eliminate swelling. If we don't have swelling, we don't have pain. If we don't have pain, it makes me look smart. Antibiotic is a precautionary thing. Again, if there's no infection, active infection, there's really no good reason to give an antibiotic. We don't need to give an antibiotic if there's no infection. But as a precaution, we don't know what's floating around. We'll give you a low dose of antibiotic over a period of time, and in Motrin usually is adequate. 600 milligrams, 3 Advil, or we can give right your prescription. Okay?
I take I pre-med for this.
Perfect, perfect. Then you're in great shape.
Yeah.
Awesome. So you can see the process is fairly routine and fairly simple. I would like you to take radiographs along the way. Maybe we can do a post-operative CT if you wouldn't mind, and we can add that to the video that will be put on our website later. Now we're going to remove the front tooth. How are we doing?
I'm doing all right.
You want to tell the camera how what the experience was like, at least for this first one?
He wants me to talk and I'm all numbed up. Imagine that. It was, to me, it didn't seem any different than any other dental procedure. All the same sounds are there. That's probably what's going to freak out more patients. But to me, it's not. It was no different than having a cavity filled. So it was fine, I guess.
Did you feel anything special? Pushing, tugging, pain, discomfort?
No pain, no real discomfort. Of course, there's pushing, and like I say, the sounds when you were drilling into my jaw. You know, that might be the only thing that patients might find objectionable.
Okay.
But
so if you had some headphones, that would be good too, right?
Yeah, that would probably be helpful. Yeah, but I don't care. So. Yeah.
All right. So now we're going to take out the. Have you put your glasses back on? So we're going to remove the tooth, and I showed you several ways of removing a tooth. We use the autotome. We use the physics forceps. We talked about conventional techniques of using a periotome, a luxator to remove a tooth, and then a forceps. Another approach that we have is a piezo, and this is called a piezo cube from Acteon. It's a really wonderful piece of equipment, and what we're going to do is we're going to use the piezo to break down the periodontal ligament and see if we can get this tooth out. You saw the external resorption of the tooth, so the tooth could potentially, the coronal portion or the crown portion could crack off, but let's see how we do using the piezo. Once we do that, we can evaluate the socket site. So we're taking out tooth number 9. You can actually see the defect, and what the piezo does is it creates vibration, and will eliminate the PDL without damaging the facial plate of bone. That's what we're hoping for here. And what I'm doing is a lot of water, and I'm simply kind of soft, going around the tooth, and you certainly don't have the power to do this with just a periotome, and you can see how deep I'm able to go very efficiently. trying to maintain the facial plate of bone if possible. So rather than using a conventional periodicone, we're able to see if we can move the tooth. Let's demonstrate the physics forceps here. As we talked about, physics forceps has two components: the beak, which is the shovel-shaped edge, which will engage the tooth, the tooth root, 1 to 3 millimeters subgingival. The bumper is simply a center of rotation, a pivot point. So you're going to feel a little pressure here, should have no pain, okay? And so what I'm doing is engaging the beak as far down that vestibule as possible, far down the tooth, the palatal portion of the root as possible, and placing the bumper as high up the vestibule as possible. And I can hold it with one finger, and if you retract back, you can see I'm really not squeezing the instrument at all. So my positioning is really just elevating towards the nose. And I'm putting tension with one finger. And we're building up energy. I'm not squeezing. We're simply building. Just take your time. You heard it pop. Okay. And then we'll simply take a tooth delivery instrument of some sort. And let's see where we are. Again, this is resorption here. So I'm simply, very carefully, very slowly removing the tooth. Without potentially damaging the facial plate of bone. We saw in the CT how thin that facial plate was. So what are we going to do next? We're going to take our curettage, correct? And we're going to evaluate. And I feel a facial plate. So let's go ahead and take my Orban. And remember how important that interseptal bone is. And I'm going to reflect this for you with my envelope. Feeling it, you don't necessarily have to reflect it, but I just wanted to show you, show everybody in the audience what we're able to accomplish. Be careful in there.
Can you turn a little to me?
So you can clearly see there's a facial plate of bone there. Can everybody see that all right? There's a facial plate. So what we're going to do is we're going to go ahead and place our implant, but now I have complete control. I can actually see that facial plate. It's intact. I hope everybody's clapping right now. And but we will do our osteotomy, 3 millimeters, palatal to facial aspect, engaging the palatal wall, and we will place the implant, but graft the site first and then thread right into the edentulous site. How's our patient doing? Okay? So if I could leave you with one thing here, it's imperative that we have complete control. And you can see, hard to see on the video, but I'm looking at tooth first, getting my angulations just right, and I'm going to engage that palatal wall. Turning my handpiece back up to 800 RPM. 3 millimeters. Palatal to the facial aspect. Could you put a perio probe on? So, yeah, see, you can clearly see. So I'm gauging the palatal wall. That's fine, thank you. And then we'll suction. I'm going to go to my 3.0 diameter burr. I can clearly see that line. I'm trying to use 2 hands here. Suction, please. Suction, please. And I want to go about 1 millimeter into that socket. And you can stop and take a radiograph along the way. 3.5 diameter. Sorry. No, I'm watching the video. And this will be a nice shape of the final position. And again, you would take radiographs throughout this process. And again, same procedure. We're going to engage, open the clothespin, and check to see the rotation. So we have our defect here, and we're not going to suction now. And I'm simply going to take my allograft material that I wetted, and I'm going to place it into the socket. If it touches the tongue, do not grab it off the tongue. And it's just simply like caulking. And just enough. Can you suction that little piece off the tongue? And I'm not packing it firmly, it's just loosely packed there. And we'll go to our implant motor. And you can see very slow, engaging. I can actually see it because I reflected it. Okay. Position of that implant. I'm just going to go a little bit more here to check my torque. Hold that for a second, please. We were at 25, so I'm going to turn it back to 25. And I'm just going to go a little bit deeper in that area. Yeah, that's awesome. Now this is a immediate extraction grafted site. To the position we want. Let's take a peek at it. So I'm looking at there, that's a pretty good shot. You can kind of see the position of that implant, about 3 millimeters palatal to the facial aspect of the adjacent teeth. So I'm pretty happy with that positioning. And I'm simply putting my cover screw, and we're going to bury this implant. Now what I want to leave you with here is, if we had a facial defect, then we could have put this membrane in that area. Okay, and I pre-cut it, and what we would simply do is slide it down past any defect. I don't have a defect here, but I just want to demonstrate what we're able to accomplish. It's not going to hurt to have this membrane there. And can you see how it's passive, doctors? There's no mystery here. There's no forcing, tugging, or anything like that. I'd give it a good squeeze, and you can see that I did not damage my interseptal bone. I maintained the facial plate of bone, and then let's just go through the surgical procedure. Everything that we've learned. Take an instrument, that has a little flat area on it. And initially, so you don't grab onto it, if she can just hold it like that. And as we talked about before, we go from crestal to facial. And then I'll simply turn the needle around, my reverse cutting needle, and go, you can let go now, you can let go now. And I'll go from crestal to palatal. And same thing, 2, 1, 2. That knot will not come loose.